So, my name is Derralynn Hughes. I'm a haematologist and I work at the Royal Free London NHS Foundation Trust. I work there in the lysosomal storage disorders unit, looking after patients with Gaucher disease. And so I've been particularly interested this year to work with CheckRare CE and CME to review some of the highlights of ASH 2020 as they relate to Gaucher disease. Our learning objectives for this presentation is to describe the latest research being presented to better manage people with Gaucher disease and to understand its clinical relevance. The Annual Society of Haematology, with more than 20,000 attendees. This year, of course, because of the COVID-19 pandemic, it was a virtual meeting. And whilst there was a lot of data presented, the meeting lacked its normal urgency, possibly because of the difficulty in having live discussions in this context. However, there were a number of presentations related to Gaucher disease. Gaucher disease is most often diagnosed by haematologists and is often treated by haematologists, but it requires a team approach of various different specialities, including orthopedics, rheumatologists, metabolic bone disease, paediatricians and geneticists. And so not all of those people would be present at ASH to have understanding of Gaucher disease. However, I hope by this presentation, some of that work that's presented might be accessible to all of our multidisciplinary team. Gaucher disease, being a rare autosomal recessive condition, can sometimes have many years of delay before a diagnosis is finally made. Common signs and symptoms include hematological abnormalities, such as anemia and thrombocytopenia, and organomegaly, including splenomegaly. There's also problems with the bone, including bone infarction, osteonecrosis, pathological fractures. And many patients have radiological evidence of bone abnormalities. The diagnosis of Gaucher disease can be challenging due to the heterogeneity of the condition and the wide range of presentations with non-specific symptoms at different ages. So, in order to improve the length of time that it takes to diagnose patients with Gaucher disease, we've made a number of efforts over the years to educate people who might be in a position to make those diagnoses. However, we know that it's impossible to educate everybody who might be in that position. One possibility that might have greater reach is the use of machine learning algorithms and artificial intelligence to automatically suggest the possibility of the diagnosis of Gaucher patients in large populations. This abstract, presented by Shoshana Revel-Vilk, proposes an algorithm which might be used to create that diagnostic possibility. In this study design, a retrospective observational database using 2.2 million health records will be interrogated for the possibility of Gaucher disease diagnoses. The concept is that an algorithm will be created using a supervised machine learning calculator and also some possible elements of diagnosis from a previous Delphi consensus. Individuals will be identified and then tested for Gaucher disease using lyso-Gb1 elevation as a biomarker. It will be compared with patients who are known to have Gaucher disease and newly confirmed patients with Gaucher. Those results will be fed back into the algorithm, and that will be further improved by the supervised machine learning. This is the GED-C scoring system, which was derived through a Delphi procedure where participants suggested the likelihood of a diagnosis of Gaucher disease based on various symptoms. Various points were attributed to different clusters of symptoms, and this can be used in a machine learning algorithm to suggest the likelihood of patients with different combinations of symptoms having Gaucher disease. You can see that those symptoms which are of high likelihood, such as splenomegaly, or in type 3 patients, disturbed Docker multifunction are given a high number of points, whereas those which are more common and perhaps more vague in relation to the diagnosis of Gaucher disease, such as gallstones and fatigue, are given a lower number of points. So the aim of the study overall is to develop that algorithm to help the diagnosis of Gaucher patients independently of the clinician's ability either to recognise the signs or symptoms or to have had an awareness of Gaucher disease. That early diagnosis should have a positive impact on patients' care and also quality of life. And we look forward to hearing the results of that algorithm and how it might be used more generally for those of us who are interested in diagnosing Gaucher. Further study addressed diagnosing Gaucher patients in high-risk populations. This was by the Italian group and was based on a study published in 2016, which showed a prevalence of 3.6% of patients with splenomegaly and or thrombocytopenia having Gaucher. This is a follow-up to that original study. The inclusion criteria were again splenomegaly and or thrombocytopenia, but at least one other symptom of either anemia, bone pain, monoclonal gammopathy or polyclonal gammopathy in patients under 30 years, or splenectomy. And those patients who had other possible causes for those symptoms, such as hemato-oncological malignancy, portal hypertension, for example, were excluded. So the results here showed that the population encompassed around 90% of patients with splenomegaly, up to 50% with thrombocytopenia, and over 20% also had anemia. And out of that group of 455 patients, 3.3% of them were found to have Gaucher disease. In addition, a patient with Niemann-Pick B disease, so acid sphingomyelinase deficiency, who had similar signs and symptoms to the patient with Gaucher disease, was also detected. And I think this consistent pickup rate of around about 3.3% shows the power of using splenomegaly and thrombocytopenia in patients who have no other cause for those symptoms and physical signs to be tested for Gaucher disease. I'm now going to consider some of the comorbidities that we occasionally find in patients with Gaucher disease. Gaucher disease has been found to be linked to various malignancies, and in particular, hematological malignancies. A study presented by Barry Rosenblum again looked at Gaucher disease and cancer. There is data available in the ICGG registry since 2005. Previous studies from the registry suggested that there was an increased incidence of hematological malignancies, in particular myeloma. Data again was extracted from the ICGG registry and compared to SEER data. Found that there was MGUS in 121 Gaucher patients and cancer in 245, and this concluded both hematological malignancies, such as non-Hodgkin's lymphoma and multiple myeloma, but also non-hematological malignancies, such as skin and breast cancer. Most of these patients were on enzyme replacement therapy. So the authors concluded that in this era of enzyme replacement therapy, there still remains a risk of multiple myeloma and non-Hodgkin's lymphoma in patients with Gaucher disease. And the rate of those cancers in patients with Gaucher is higher than the general population. There's also a risk of liver cancer, renal cancer, and melanoma. They also noted that the risk of MGUS in patients younger than 50 years is also unexpectedly high. And these findings underscore the relevance of cancer screening in patients with Gaucher disease type 1. We previously suggested that screening patients on an annual or biannual basis for serum protein electrophoresis for evidence of a paraprotein would be a useful adjunct to our investigations in Gaucher patients. And I think this study further supports that as an investigation. Other comorbidities include neurological manifestations, even in patients with type 1 Gaucher disease. And it's now been well accepted that Gaucher disease and carriership of Gaucher disease of the GBA gene is linked to Parkinson's. So there may also be the possibility of Gaucher disease being linked to other neurological symptoms. In this observational study from Derralynn and others in the Italian group, there was observation of not only Parkinson's motor signs, but also cognitive impairment, anxiety and depression, abnormal eye movement, sensory and neural hearing loss, and excessive daytime sleepiness. So all GD3 patients showed a wide spectrum of neurological abnormalities, and that's much as expected. However, all Gaucher disease type 1 patients also presented with at least 2 or more clinical signs or symptoms of neurological disease. I think this raises important questions as to how we view the neurological spectrum of Gaucher disease, but also in particular making sure that we don't miss the diagnosis of Gaucher disease type 3 in patients with late presentations who've otherwise previously been classified as Gaucher disease type 1 patients. Further presentation was actually looking at Gaucher disease type 3. It was an observational study from a large cohort of Egyptian patients with GD3. These are patients who'd been followed for more than 20 years receiving enzyme replacement therapy. The median age of diagnosis was round about 1 year. More than half of the patients were in fact diagnosed in the first 2 years of life. 75% of those patients were L483 proline homozygous. 76% had anemia, 22% thrombocytopenia, and 49% splenomegaly. Overall, 71% of those patients survived more than 20 years, with no correlation to baseline symptom severity. And I think it's particularly interesting that they found 20 patients died from disease complications, including pulmonary manifestations as well as neurological disease. They found that enzyme replacement therapy was very successful, and data presented showed effects on liver, spleen, hemoglobin, and platelets. So I'd like to complete this short presentation by considering the potential impact of COVID-19 on patients with Gaucher disease. There have been a number of recent discussions and presentations in journals as to whether Gaucher disease patients might have an adverse effect from COVID-19. However, 2 recent studies have also suggested that Gaucher might in fact be protected from COVID. One study from New York looked at 180 patients with Gaucher disease. Of these, 16 patients proved to be positive for SARS-CoV-2, but in fact none required hospitalization, and there was no increased risk of serious events as a result of COVID-19. In a further study from Professor Zimran, looking at Israeli and Australian patients, 550 patients were examined, and in fact only 1 patient tested positive for SARS-CoV-2, and this patient had mild symptoms. There's speculation that glycosphingolipids might actually protect from COVID-19 infections. I think it's important that as we go forward and learn more about Gaucher disease and COVID-19 that we collect data so that we can appropriately advise patients precautions on vaccination and what they might be likely to know. So thank you for your attention, and I hope you agree that, as always, there were some interesting abstracts presented in relationship to Gaucher disease at ASH. Again, there are many patients with Gaucher disease who have late diagnosis and many people in the population who remain undiagnosed. I've illustrated a couple of studies related to machine learning algorithms and clinical algorithms for the diagnosis of Gaucher disease. And we've also looked at some comorbidities relating to Gaucher disease, including cancer and increased incidence of neurological conditions. We've also thought about enzyme replacement therapy for Gaucher disease type 3 and looked at an abstract which showed the improvement in the systemic manifestations of GD3. Thank you very much for your attention.